be able to compete with the previous photos. Try to do my best otherwise. Okay. The internal thoracic artery has been established as the preferred conduit for coronary artery bypass grafting, reflecting superior histological vasoreactive properties as well as superior graft patency. To maximize utilization of ITA conduits, and the benefits, sequential grafting of the LAD and the diagonal artery has been proposed. And the standard technique, as everybody knows, is the diagonal first sequential grafting. This is the technique which is been routinely has been used or is used around the world. The LITA, in situ LITA, is being used for sequential grafting first, diagonal first of the LAD, of the diagonal artery, and then of the LAD. Now, this technique has been shown feasible, reproducible, with good results. However, it entails inherent disadvantages, and the disadvantage, the major disadvantage, that in any case it warrants a prior LITA anastomosis that may compromise the subsequent LAD anastomosis. Thus, may risk the LAD, the more important LAD revascularization. And here we have to emphasize that the problem can be technical error, and we are always potentially subjected to technical errors, particularly if the target vessels are not in good shape. But the second problem is the competitive flow. And despite, irrespective of the technical accomplishment of the anastomosis, the LAD, the subsequent LAD anastomosis can be affected, negatively affected by the competitive flow during time. The second problem is that the distal LITA segment, okay, it's not the LAD, the distal LITA segment, which is usually small calibered and much more vasospastic, is used for the more important LAD anastomosis, particularly if the target vessel or the localization of the target area in the LAD is very distal. Now, previous works that have been analyzed the standard technique, the standard sequential LITA grafting, have shown that basically 80% of the problems occur in what defined as the peripheral segment. That means the segment after the LAD or the anastomosis itself. And this is a work in the Annals of Thoracic Surgery from 2003. Now, this is also something that limits us or restricts us from using the standard technique, that we have to take in consideration geometrical and anatomical issues, and usually this technique is not feasible, at least that's the way it's been described in the literature. The standard technique is not feasible when the LAD diagonal angle is more than 60 degrees and the lateral distance is greater than 4 centimeters. Now, in order to offset or to counteract these disadvantages of the standard technique, an auto-Y LITA composite has been recently proposed, and being occasionally used. And in this technique, what is being performed is that the distal LITA segment is usually being resected and reimplanted as a Y technique, in a Y composite, small Y composite, to graft the diagonal artery. Now, this alternative technique has been proposed to avoid using the distal LITA segment for the LAD. But again, the inherent problems of the previous technique remains, and we're still subjected to technical errors because there is a prior LITA anastomosis before the LAD. So we're still subjected to technical errors, to competitive flow between the two arms of this small Y composite, and additional problem is that we have an additional anastomosis. Okay, so the purpose of this study was to evaluate a novel LAD first technique that has been previously presented here with regard to its clinical results for single LITA vascularization of the LAD and diagonal artery using skeletonized LITA in inverted J configuration. Now, long-term LAD and diagonal artery patency rates were assessed in symptoms-directed angiograms, and I would like to emphasize that all the work is only in symptoms-directed angiograms. Now, data were derived from patients undergoing primary multivessel. All patients underwent multivessel coronary artery bypass during 2006 and 2013. Most of the patients are patients who underwent double bilateral ITAs and complete arterial vascularization. Concomitant LITA and diagonal artery was performed in 556 patients, either by the standard sequential grafting, D-first technique, or by the inverted J configuration, LAD. First technique, which comprised 289 patients, 52%. This work concentrates or focuses on 75 symptoms-directed angiograms in 75 patients for 150 LAD anastomosis. All LITA conduits were harvested as skeleton eye vessels, and the LAD first concept was achieved by a longitudinal side-to-side LITA to LAD anastomosis, followed by a reversed end-to-side LITA diagonal anastomosis forming inverted J configuration, as being seen here. That means that the LAD is grafted by a side-to-side longitudinal LITA anastomosis, and then the distal segment is reversed backward to reverse anastomosis on the diagonal artery. And here you see it on the angiogram, that basically anastomosis on the diagonal artery is reversed. What we achieve in this manner is that a good segment of the LAD is used to graft a good segment of the LITA is used to graft the LAD more proximally, and the distal segment is used for the less important diagonal artery. Now, postoperative angiograms were invariably symptoms directed, as previously mentioned, and the status of the freedom from graft failure was classified by as basically as patent or non-patent, and the faint non-functional angiographic definition was, or non-visualized, were defined as occluded grafts. This is also something that you have to look at, because when various works, definitions of patent are very different between works. In many cases, patent, if there is still flow, even faint flow distally, anastomosis are defined as patent. Here not. Here anything that, unless it was perfectly defined as perfectly good anastomosis, and it was defined as non-functional, non-patent. Now, catheterization follow-up of catheterization ranged from 1 month to 107 months, and the median was 62 months. Overall, both techniques, freedom from graft failure, we refrain from using the word patency rate because, again, it's only in symptoms-directed patients, so we define it as freedom from graft failure, either in the distal anastomosis or in the distal segment. So after 8.9 years, the overall freedom from LITA, sequential LITA to LAD graft failure was 92%, and the freedom from LITA to diagonal artery was 93.3%. Now, 82%, and this is compatible with the literature, 82% of the LITA graft failures were confined to the distal ITA segment. And you see only 18 basically it was significantly between the proximal and distal anastomosis. Now, in the LAD first technique, we had 40 patients who underwent angiograms and 35 in the diagonal first at comparable median time to re-angiogram. And with regard to results, we had 97.5 freedom from graft failure on the LAD territory. On the diagonal, on the LAD first technique was 97.5, and 85 compared to 85.7 LITA to LAD graft failure in the standard technique. And this is after 5.2, basically after 8.9 years, but with regard to the angiograms after 5.2 years. And here you can see that there were reduced problems in the LAD territory on the LAD first technique. With regard to the diagonal territory, there was basically non-significant difference between both techniques. So to conclude, irrespective of the technique, lethal graft failure, sequential lethal graft failures were confined to the distal segment, and the percentage here was compatible with the literature, around 80%. And the results herein reflect better freedom from sequential lethal graft failure in the LAD territory. And we have to emphasize these results reflect symptoms-directed angiograms and should be accordingly considered. And to conclude, we think that the inverted J technique, with all limitations of this work, small numbers and only symptoms-directed patients, we think that the concept of the inverted J technique may achieve superior freedom from lethal to LAD graft failure, and thus recommended whenever technically feasible. Thank you.